And now I have to present one great surgeon, actually, from Athens, Apostolos Rubelakis, who actually convinced me that he knows his job. He knows his art, actually, in order to repair valves. And actually, he has, if it is possible, 12 minutes in order to convince us about new methods of your talent.
And it's not just about new methods, it's about limitations as well of the new techniques in mitral valve repair. No, it's not about mitral clip. It's actually something better than mitral clip. We're going to chat about it later. I would like to thank the organizing committee, Kostas. I'm really grateful for inviting me to this fantastic meeting once again. We talk about quite a lot about how we repair valves, and we have very nice videos showing what's going on. And I think the conflict of interest I have is I'm just going to say when we should do it and when we should not do it. But before I start my talk about how we do it with small scars, I think it was mentioned earlier, it's nice to remember why we would like to repair the valves, why repairing a valve is better than replacing it, and it's all these benefits that we have for the patient that you can see on the slide. And I have to convince everyone that actually repairing a valve is a lower risk operation. Even in the recent years, the risk of replacing the valve is an amputative surgery, so the risk is higher. Repairing the valve has a lower risk, less risk for thromboembolism and infections and bleeding, and less medications, and excellent long-term outcomes. And that's why they are so high, the mitral valve repair is so high in the guidelines, and even with a 2A indication for patients that are even asymptomatic, in experienced hands, we have good chance of a valve repair. Low risk operation for what we talk about. My talk is about prolapse, so we talk about degenerative mitral regurgitation. We have a 1.1% risk. It never gets down to zero. And you have to remember that we talk about young patients with not many comorbidities. But again, you can see that the risk of a replacement is around 5.8%. So there is a significant difference. And there are other series from across the Atlantic which show the 1.5. So it's between 1 and 2%, I would say, the risk of repairing a valve. But we have to remember, but mitral valve repair does restore the normal life expectancy of the patient once it's done in time, which means that if it's in New York Heart Association 1 or 2, then the patients, it doesn't matter whether 40 or 50 or 60 or 70 years old, they're going to go back to their normal life expectancy. And especially when we talk about cordal replacement and placing a ring, which is the most modern way of treating degenerative mitral regurgitation or prolapse, if you want, it has a less than 10% risk in 10 years of reoperation, and has a very good long-term survival. Now, I have to. The reason why I'm placing this slide is it's coming from an old talk. However, we talk about the Barlow disease. Barlow disease or bileaflet prolapse is not the worst. Isolated anterior leaflet prolapse is the worst, actually, and it's more difficult to repair for us, because the forces that are at the tip of the anterior leaflet are much more different, and it's much more difficult to repair with cords, and that's why early failures happen. Bileaflet prolapse and posterior leaflet prolapse, which we're quite lucky are the most common, let's say, anatomies of degenerative mitral disease, are actually easier to repair and have excellent long-term outcomes. You can see here in this graph, if you have a posterior leaflet, if you repair it properly, then it's going to last more than a mechanical valve. So a step forward about minimal invasive or endoscopic surgery, which means actually we avoid stenotomy, and we can use endoscopes. It can be totally endoscopic, it can be video assisted, it can be even direct vision. What we avoid is reduce the trauma. That's the main reason we're doing it. We try not to do a stenotomy, and we have some benefits coming from it. And it's not something that we found out 10 years ago, 20 years ago. It's something that started happening back in 1996, where the surgeons had started applying smaller incisions at the lateral side of the chest to repair valves like mitral valves. But now we have different weapons in our hands. We have 3D vision, we have better instruments, so we're better in doing it, something that was an idea of happening 30 years ago. And these are the usual cuts that we do. It's either going to be an incision below the nipple, or it's going to be even smaller incisions like around the nipple, which are completely invisible. Doesn't make much of a difference. Whatever the surgeon is comfortable, there's not much benefit that's been documented at least, between the one or the other. And we need specific instruments. We need, obviously, cameras, and the toy at the bottom end of the slide is actually a new intercostal RF ablation that I use for my patients to make them specifically pain-free, even if I have to stretch the ribs a bit in order to do the operation. We have to go on cardiopulmonary bypass, obviously. Many patients ask me, well, you're going to do a cath here. Is it going to be like a mitral clip? That's why people are getting a bit confused. We have to go on pump. It's still an open heart surgery. Okay, it's an open heart but closed chest surgery. And we use some specific venous cannulas that go all the way to the SVC and cannulas that bring back the arterial blood from the femoral artery. But we're rewarded by this nice view. And you can see, basically what you see now, it's the left atrium, and you can see the view of the valve from the left atrium. Resembles quite a lot the nice images you have from 3D echo. And we can do a repair the same way you would do it basically in open surgery. The white stitches you see are artificial cords. And what I'm doing now, I'm closing a cleft with a stitch between the P1 and the P2. And there are the other stitches which are a bit dark all around the annulus, which are the stitches that help me put a ring on this patient to stabilize the correction I'm going to be doing. So this is the most typical, let's say, repair that we do without a stenotomy, minimally invasive repair. Now the ring is in place. We do some static testing with some water to make sure that the valve is competent. And once we're finished with that, we close the incision, we close the chest, and the operation is done. So it's not just for P2 prolapse, though, and there are more complex cases that we can do endoscopically. And this patient is a young lady who had a mitral disjunction and a Barlow disease with bileaflet prolapse. Most of the prolapse was coming from the posterior leaflet. And I have to say that Barlow disease is not that difficult to repair. I know it's a bit provocative what I'm saying, especially when the prolapse is equal between the two leaflets and you get central jets. It's just usually just a ring will do the job with a very good long-term follow-up. So for this patient again, okay, so we have excess tissue. We had to put some extra, as you can see there, I'm stitching right at the head of the papillary muscle. I'm putting some artificial cords, and I'm using a cheap ruler to try to achieve some vision below the level of the annulus. We tried to fix the prolapsing segment on the posterior leaflet. On the anterior leaflet, we didn't have to do much. Then we placed a semi-rigid ring at the posterior annulus, and we had the result that you can see echocardiographically at the bottom right of the screen, which was quite good, 0 MR. That's the semi-ring that goes down. It's a long discussion why I'm using a semi-ring on this patient instead of a full ring, but it's going to be a different talk. Can we do other stuff apart from fixing the mitral valve? Yes, we can do. That's my way of treating the AAF. I'm using a cryo balloon. That's the same Medtronic cryo balloon that's been used in a cath lab. And I'm going to all the pulmonary veins. I'm inflating the balloon, and I'm having a very good result of cryo. We have a problem in Greece with legislation when it comes to cryo devices. So we have to use cryo only through this platform. Excellent results because the heart is arrested and empty, so the temperatures that we achieve with the cryo balloon are much better compared to the ones that happen in the cath lab. And we go to all 4 pulmonary veins, and we can do this quite quickly. We can also cover a bit, let's say, the entrance of the left atrial appendage. We usually do this before doing the operation to the mitral valve, and we can carry on and do this to all 4 pulmonary veins. And I think I should move forward instead in the next video and show you that apart from sorting out the mitral valve, we can sort out also the tricuspid valve. It's just an incision to, once we finish with the mitral valve and we do the operation on the mitral valve, we just carry on in the tricuspid valve, and maybe I should forward a bit this video to show you that that's the result of the mitral valve. Then we close to go to the tricuspid annulus. Now we're in the right atrium. We place some sutures around the tricuspid annulus, and it's just the placement of the semi-complete ring. We go down here. We have some special like small automatic knot fasteners which help us tie faster these knots around it. And we test the tricuspid valve. We have a good result after the operation. I think I have some images of the echo once we finish with the mitral and the tricuspid valve, which is also 3D. It's a team play, though. It's not what I'm doing in the operating room, because I have to deal with the anesthetist and I have to deal with the perfusionists, which are well trained, and the same applies to my scrub nurse. And it's also, I'm one of the few probably surgeons that I use a cardiologist in my operating room. I don't really rely on the TOE images taken by anesthesiologist, and I usually want to have some proper 3D test because I want to have certified result before and after the operation. So people like Kostas and like Stefanos come to the operating room, whether I'm operating in Athens or Thessaloniki, and they make sure that I have a good result. And this is the only way forward. I think we should do these procedures. And of course, there's a cooperation between the ward teams and the ICU, and we have to have some executive support by the hospital and financial support, et cetera, et cetera. But is it just reducing the scar that makes them the benefit? Well, it gives us all the short and mid and long-term benefits. Less trauma, less transfusions, less risk of infection, faster rehab, less amount of pain, shorter length of stay. These are not 100% though. We haven't got very strong trials to see this, and we're going to talk about it a bit later. And then we return quicker to the lifestyle. The patients love their incisions. They don't feel like they've done a proper cardiac operation, despite the fact that they've done actually a proper cardiac operation. And it's actually quite safe because we do use the same things we would use in an open procedure, so the results are equally good. The only randomized trial that's out on the market is the UK mini mitral trial. It was not a well-designed trial because it was designed for superiority. However, it compared on a fashion that was randomized, two types of patients, sternotomy and non-sternotomy. It did show that the operations were safe and the repairs were excellent, but the quality of life was not actually that improved. It was improved for the first 3 weeks for the patients that underwent non-sternotomy operations, but after that, at 6 weeks, it was equal. However, it did show another marker that was better for patients that underwent mini surgery. What was that? The quality of life, which is derived by the days alive and out of hospital. It's something that we're probably going to hear in the future quite a lot, because it doesn't matter whether we're alive or not after an operation, but we have to be out of hospital as well in order to have a quality of life. And there was a significant difference between these two techniques, but there was a small price to pay. Operations took longer when we were going for mini access, which means that cross-clamp time and bypass time and procedure time were a bit longer, and this has its own meaning. To whom we shouldn't do this operation then? Well, it's actually the peripheral bypass that makes a limitation. Severe peripheral vascular disease, small caliber peripheral vessels, probably should change our strategy. More than moderate aortic regurgitation is not safe to give cardioplegia to stop the heart. Congenital vascular anomalies, for example, if we have inferior vena cava that's not draining to the ventricle, to the right atrium. And also there are some relative contraindications like obesity, hostile chest with chemotherapy or previous operations, or radiotherapy, or chest operations and chest wall deformities. And I had this 40-year-old lady, mitral annular disjunction, mitral annular calcification, and she had a Marfan's disease, a pectus, a kyphoscoliosis, which was operated on. And I had to go through the right chest to do an operation on this valve where you can see where the posterior annulus is. It was impossible. So I had to do sternotomy for her. It's not the usual operation that you can do in a minimal invasive way. And it's not a problem with that. The result was still excellent, okay? But what we have to do, the other relative contraindication is time. If the operation takes much longer than expected, based on surgeon's experience, then there is a trouble. Why is there a trouble? Because we know that the longer the bypass time takes, the worse the outcomes. When you pass the mark of approximately 4.5 hours, patients start developing comorbidities like renal failure, need for dialysis, stroke, etc., etc. But it's not just the bypass time, it's also the cross-clamp time, the time that we keep the heart in ischemia and in cardioplegia. We know that once we go through the 100 and 120 minutes, then complications start to develop. So when we start thinking about getting a patient on a mini mitral operation, we really have to think how long it's going to take, because we have to do too many things. Then, well, if we already think these things are really complex, then we're better off with the sternotomy if we feel that we're going to be quicker through that way. And also, it's the learning curve. Well, they say you have to do 100 operations to be good at that, and maybe you have to keep your skills by doing 1 operation each week. More or less, the centers that are dealing with this are managing to achieve these numbers. Otherwise, it's not going to be viable. But the longer you're getting trained, the quicker you are, the less conversions, less complications you have. And it's not for every surgeon. There are surgeons that pick up this procedure quite well. There are surgeons who are really talented. There are surgeons who are very good surgeons doing this operation through sternotomy, but they can't really do it through minimal access, and that's at the bottom of the graph here, which actually do not perform well no matter what. What about higher risk patients? Well, there has been some data which comes from the Mini Mitral International Registry, and then Salonique is also contributing to this registry, which shows that if we go past the Euro score of 4, well, the results are not that great. Doesn't mean that they're really high, but the mortality, once you go past the Euro score of 4, from 1% jumps to 3.4, and then to 3.7, then 14%, which means that you have to be really cautious about a high-risk patient with these, with a poor LV function, these with a severe pulmonary hypertension, these who have renal failure, that you need to have the quickest operation that's going to be safer for the patient. The benefit of having a smaller scar probably doesn't justify going through the side of the chest. Despite all these, the numbers are equal, and there are many registries that show that there's not much of a difference in mortality, and it's actually happening quite a lot. We used to do these procedures probably 1 in 5 in the past, and now almost 50% of the operations that are isolated or concomitant mitral and tricuspid surgeries are happening in the endoscopic way. And there are some further steps that we need to take in order to improve outcomes further. Early extubation in a few hours, ICU stay for a few hours, early fusion rehab, quicker relative contact, data organization. We need to have the patient more on the right side of the screen than the left side of the screen. And I just want to conclude by saying that the endoscopic or minimally invasive mitral surgery is here to stay because it's a safe alternative to traditional surgery and provides benefits for the patient. It's difficult to design a very good randomized control trial about it, but there is some difference, and we see it every day in the patients we operate on. The range of indications will eventually increase because we have so much industry going on and so much better instruments as time goes by, which can help us reduce the time and reduce the limitations and the relative contraindication which we have for these patients. In this way, we can achieve optimal results. Thank you very much.
Thank you very much, Apostolos. It was an excellent presentation. And